A patient arrives by ambulance. Gunshot wound. Critical. The trauma chief barks orders. A young woman in fresh scrubs moves through the controlled environment. The rookie nurse, barely 3 months in. The chief dismisses her assessment. You don't have the experience for this call. She steps back. Silent. Accepts it. But then, something shifts. When the chief misses a critical detail, she notices it first. When he hesitates on a tactical medical decision, her eyes recognize the mistake immediately. Her hands move with absolute precision. Not nervous, not learning. The fluorescent lights haven't warmed yet. Sarah Chun hangs her jacket in the staff locker and checks her phone. No messages, before switching it to silent. Her scrubs are still crisp. The embroidered name tag is fresh from the laundry. Everything about her says 3 months. Everything about her movements says nothing at all. The unit is quiet before the shift change. 2 nurses moving slowly through pre-dawn routines. A respiratory therapist checking ventilator settings on an empty bed. Dr. Marcus Reeves sits at the nursing station with a coffee, reviewing overnight admissions. He doesn't look up when Sarah passes. She's invisible to him. This is intentional. The trauma chief, that's Reeves, 38 years of surgical experience, reputation for running the tightest bay in the state, finally glances at her as she begins her equipment check. His eyes move across her like light across still water. Young, uncertain, temporary. Chun, he says, not unfriendly. Who trained you on line draws? Orientation covered it, she says. And before that, nursing school. He nods once, returns to his coffee. She's already been categorized. She knows this. The categorization is accurate by every measure except one. By 7:15 a.m., the first patient arrives. The ambulance radio crackles at 7:13. 62-year-old male, fall from a ladder, possible head injury, consciousness declining. Sarah is positioned at the 4th station. Standard role. Reeves moves to the head of the bed automatically. The attending physician, Dr. Paulson, takes the other side. This is the hierarchy. This is how it works. The patient arrives conscious but confused. Speech slurred. Left pupil slightly dilated. Reeves is already calling for a CT scan, already running through the primary survey with mechanical precision. Sarah watches him work the way a junior officer watches a senior one, learning, deferring, moving to support his decisions before he states them. When he says get 2 large-bore IVs, she's already moving. But when she inserts the first line, Reeves watches her hands. She sees his attention sharpen. It takes her 1.3 seconds. No hesitation. No second attempt. The line goes in smoothly. She's already drawing labs. Careful with the draws, Reeves says. Make sure you're getting the right tubes. She looks at the draw she's already completed. It's perfect. But she nods. I will. This is the agreement they're making. He gets to correct her. She gets to be corrected. It's how trust is built between an experienced surgeon and a rookie. It's also how she stays invisible. The patient is moved to CT. The bay empties. Reeves reviews the notes Sarah has documented. His expression doesn't change, but he reads them twice. Good work on the initial, he says. Thank you, Dr. Reeves. By 8:45 a.m., the second patient has already been admitted and discharged. Minor laceration, sutures, observation protocol. Sarah assisted. She handed instruments, asked clarifying questions, made space for the resident who was officially learning. No one remembers her now. This is correct. At 10:30 a.m., the first patient returns from CT. The scan shows a small subdural hematoma. Reeves is reviewing the images on the monitor, and his jaw tightens. This isn't what he expected. It's not immediately life-threatening, but it's not nothing. He's already on the phone with Neuro. Sarah is updating the monitor settings, and she notices something on the EKG reading that doesn't match the patient's baseline from intake. A subtle change. A question mark. The kind of thing that takes real clinical observation to spot. The kind of thing a rookie wouldn't necessarily catch because she doesn't know yet what normal actually sounds like. She says nothing. Reeves is on the phone. Paulson is reviewing labs. This isn't her place. But she watches the monitor again. The pattern repeats. She walks to the station. Doesn't interrupt. Waits until Reeves ends his call. Dr. Reeves, she says quietly. The cardiac monitor shows a possible rhythm shift. Nothing dramatic, but it's different from his baseline strip. Reeves looks at the monitor, looks at the baseline, looks back. A pause. The kind that holds weight. Good catch, he says. And then he's moving, ordering an EKG, his attention already shifting. Paulson follows him. The moment is over. But Sarah stands at the monitor, very still, understanding that she's made a small mistake, not in what she said, but in how visible she just became. By midday, Reeves has mentioned Sarah to no one. This is also intentional. He watches her during a routine procedure, a woman with a compound fracture to the radius, requiring reduction and splinting. Standard orthopedic trauma. Sarah assists the attending surgeon, an orthopedic specialist named Dr. Kwan who comes in from the clinic upstairs twice weekly. Sarah's hands move through the prep with the kind of efficiency that shouldn't exist in a 3-month employee. She anticipates what Kwan needs before he asks. Not through observation of his patterns. They've worked together twice. Through something else. Through knowledge of what comes next in a procedure like this. Through muscle memory, wearing a borrowed skin. When Kwan needs the reduction forceps, Sarah has already positioned the tray. When he needs the immobilization materials, she's already prepared the exact gauge he prefers. Kwan doesn't notice. He's focused on the patient's arm. But Reeves is in the observation window, reviewing the case file, and he sees it. He sees her hands. The patient is moved to recovery. Reeves goes to the break room. Sarah is at the supply station, restocking the crash cart with the kind of methodical precision that suggests she's done this same task hundreds of times. Not dozens. Hundreds. Where did you train? Reeves asks. Not hostile. Conversational. The way you ask someone about the weather. Sarah doesn't hesitate. Community College of San Francisco. 2-year program. Finished 18 months ago. Worked at County General for a few weeks before I got this position. It's a clean story. No gaps. No defensiveness. County's a good program, Reeves says. He's watching her hands moving through the inventory. Trauma exposure? Some, she says. Mostly med-surg and ICU, honestly. I wanted to specialize in trauma, so when this position opened, I applied. The lie is perfect because most of it is true. County does have a good program. She did probably train somewhere. But Reeves can feel the space around the words, the things not said, the deliberate vagueness of some. Your fundamental knowledge is solid, he says. Better than most who start here. She looks at him directly for the first time. Her eyes are gray-blue, completely calm. Not grateful. Not apologetic. Just present. Thank you, she says. I study a lot. And then she returns to the crash cart. Reeves doesn't press it. This is the moment he could, and he doesn't. Later, he'll wonder if that was the moment to ask the real question. But he lets it pass, and she feels the pressure lift from her shoulders like a physical weight. By 2:15 p.m., the moment returns in a different form. An elderly man comes through triage, chest pain, possible cardiac event. He's positioned in the monitored bed, and while Sarah is running the EKG, he asks her a question. His voice is shaky, frightened. Is this a heart attack? He asks. Sarah looks at the rhythm on the machine, then at him. Her assessment is immediate and accurate, but it's not the kind of accuracy that comes from textbook reading. The EKG shows some ST elevation in leads 2, 3, and AVF, she says quietly. That pattern suggests there's an issue with blood flow to the inferior wall of your heart. The doctors are going to run more tests, but yes, you should prepare yourself for that possibility. It's not false reassurance. It's not panic. It's precise clinical honesty delivered with a steadiness that a rookie doesn't typically possess. A rookie usually says the doctor will explain it, or let's see what the EKG shows. A rookie doesn't narrate the anatomy of cardiac ischemia to a frightened patient with that specific confidence. Reeves hears it from across the bay. He's reviewing another patient's chart, but he hears it, and he stops reading. The attending cardiologist arrives 4 minutes later and confirms Sarah's assessment almost exactly. The man is prepped for emergency catheterization. Sarah documents everything, and Reeves watches her face. There's no relief at being right, no satisfaction. Just attention to the next task. She's been right about things for a long time. This isn't new information to her. That evening, when Reeves finishes his shift, he sits in his car for 2 minutes before starting the engine. He pulls up Sarah Chin's employment file on his phone. Background check, clean. References from county, brief but positive. Nursing degree, documented and verified. None of it explains what he saw. None of it explains her hands. The radio crackles at 2:31 p.m. Multiple vehicle collision on the interstate. Northbound, mile marker 47. 2 vehicles confirmed involved. Paramedics requesting multiple units. First ambulance en route with critical patient. ETA 8 minutes. Reeves is in the OR, elbow deep in a laparoscopic cholecystectomy. The OR nurse relays the dispatch. He nods. The trauma bay will handle it. That's how the system works. The chief surgeon stays in the OR. The trauma team responds. Sarah is in the bay, restocking after the morning's discharges. When she hears the dispatch, she moves automatically, clearing beds, gathering supplies, checking inventory for major trauma protocols. Standard response. She's done this twice before. Both times, the patients were minor. Both times, the bay reset quickly and returned to normal. This won't be normal. The first ambulance arrives at 2:39 p.m. A man, approximately 50, massive crush injury to the right leg from a steering column. He's conscious, screaming. BP 8852. Pulse 132. He's in hemorrhagic shock, and the paramedics are running 2 lines, pushing fluids. The attending physician on duty is Dr. Sarah Paulson, different from yesterday's Dr. Paulson, which means this is the daytime surgeon, less experienced than Reeves. She's capable, but not a trauma specialist. She takes the patient. Sarah assists. Standard triage assignment. 3 minutes later, the second ambulance arrives with a child, approximately 7 years old. Head laceration, possible closed head injury, consciousness declining. The pediatric resident, Dr. Hayes, takes this one. Sarah sees it happen in her peripheral vision and understands immediately. The pediatric resident will need support. The third ambulance arrives at 2:47 p.m. A woman, approximately 30, chest trauma, suspected pneumothorax, breathing shallow. Paramedics have already started supplemental oxygen. She's conscious, but in respiratory distress. There's no third attending available. Paulson is deep in the crush injury, working on hemorrhage control. Hayes is running a pediatric neuroassessment. The third patient is now Sarah's clinical responsibility in every way except the one that matters. She has no authority to take it. But the patient is decompensating. The oxygen isn't enough. Sarah watches the respiratory mechanics, watches the color shifting toward blue, watches the effort of breathing increasing despite supplemental O2. She's seen this before. Tension pneumothorax. The kind that kills if you wait for the attending to finish with another patient. She doesn't page for help. She doesn't hesitate. She steps to the bedside, and her hands move through the primary assessment with absolute certainty. Palpation of the chest wall, identification of the affected side, assessment of the tracheal deviation. The patient is deteriorating in real time. Sarah walks to the supply station and draws up a 14-gauge catheter. She doesn't ask permission. She doesn't announce what she's doing. She returns to the bedside, finds the second intercostal space, midclavicular line, and performs a needle decompression. The rush of air is audible, immediate. The patient's breathing eases. Color begins to normalize. What Sarah has just done, what she has done without physician order, without permission, without the institutional authority to do it, would normally be grounds for termination. A nurse performing a needle decompression is outside the scope of practice in every civilian hospital protocol in the country, unless you were trained by people for whom scope of practice meant something very different. Unless you learned medicine in environments where waiting for a physician meant watching someone die from something fixable. She secures the catheter and pages for the attending. But the damage, or the miracle, depending on perspective, is already done. The patient stabilizes. The immediate threat passes. By 3:15 p.m., the bay is managing 3 critical patients. Paulson is in the OR with the crush injury. Hayes is upstairs with the child for emergency imaging. The third patient, the woman Sarah decompressed, is being prepared for transport to ICU. She's alive because of a procedure that shouldn't have happened the way it happened. Reeves' surgery finishes at 3:22 p.m. He scrubs out and heads toward the trauma bay for the post-emergency briefing. This is standard protocol. The chief surgeon always reviews multiple casualty responses. What he finds is Sarah moving through the bay with calm efficiency, resetting supplies, updating charts, coordinating with the ICU transport team. The bay is under control. Not barely. Completely. The second attending, Dr. Morrison, pulled in from clinic, is finishing his notes. When Reeves arrives, Morrison briefs him. 2 critical transports to OR and ICU, 1 stabilized. Your trauma nurse made a call on the pneumothorax patient that probably saved her life. Needle decompression before the chest tube. Unauthorized, technically, but correct. Reeves doesn't respond immediately. He watches Sarah at the monitor, reviewing the patient's final rhythm strip, making sure the record is accurate, making sure nothing is missed. She feels him watching. She doesn't turn around. She just finishes what she's doing with the kind of unhurried precision that belongs to someone who has managed trauma responses before. Many times. In places where protocol mattered less than competence. Reeves understands now that he isn't watching a rookie. He's watching someone pretending to be one. Reeves finds her in the staff locker room. Not an accident. He's been waiting for the moment when she's alone, when there are no witnesses, when the question can exist in private space. Sarah is changing out of her scrubs, already moving toward departure. She sees him in the mirror and stops. Doesn't turn around yet. Just waits. "Walk with me," Reeves says. Not a request. They move through the hallway toward the hospital's administrative wing. No one follows. The shift is ending, and the building is emptying. His footsteps are deliberate. Hers are completely silent. "That decompression you performed," he says, not looking at her. "That's not something they teach you in community college. That's not something you learn by studying. That's something you perform when you've already done it." Sarah doesn't answer immediately. They reach the window overlooking the parking lot. The sun is moving toward the horizon, and the light is already beginning to darken the glass. "Where did you really train?" Reeves asks. Direct now. No preamble. No room for deflection. Sarah is quiet for a long moment. She can feel the decision forming in her chest like a physical object. The lie is already constructed. She could maintain it. She could add details, invoke county general stories, create a narrative around experience earned in the civilian system. She's good at lying. It's one of the skills that kept her alive. But something has shifted. He knows. Not everything, but enough. And if she lies now, the distance between them becomes intentional, becomes choosing, becomes a different kind of betrayal than simply omitting information. "Military," she says finally. Her voice doesn't change. "Medical training in the military." Reeves nods slowly. He was expecting this answer, and he was also not expecting it. The confirmation carries weight. "How long?" he asks. 10 years. "In what capacity?" Sarah turns away from the window. She looks at him directly. Her eyes are still that gray-blue, still completely calm, but there's something underneath the calm now, the weight of choosing to be seen. "Combat medical officer," she says. "Special operations. That's as much as I can tell you." Reeves absorbs this. He's a surgeon. He understands classified information in a theoretical way. The idea of compartmentalization, of things that can't be discussed, of a world operating parallel to the one he inhabits. But understanding it theoretically and standing across from someone who lives it are different things. "Why?" he asks. "Are you working as a rookie nurse in a civilian trauma bay?" Sarah doesn't answer immediately. She walks back to the window. The parking lot is filling with the evening shift arriving, unaware that anything has shifted. "I needed to stop," she says quietly. "The work I was doing, what I saw, what I did, it was becoming something I couldn't separate from myself anymore. I needed to be someone else. Just for a while. Just long enough to remember what normal looks like." It's the most honest thing she's said since she applied for the position. It's also incomplete. There are reasons underneath this reason, decisions made that led to disappearing, perhaps things that made disappearing necessary. But she's given him what she can give without exposing more than her own survival. Reeves understands this too. He doesn't press for more. "You can't do it again," he says. "The unauthorized procedures. If someone else sees it, if it becomes a pattern, the hospital will have to act." "I know, but I also know that you made the right call. That woman would have died waiting for protocol." Sarah nods. She accepts both things, the limitation and the acknowledgement. They exist together. They have to. "What happens now?" she asks. Reeves is quiet. He's thinking through the implications. A nurse with classified military training working in his trauma bay. The liability questions. The security questions. The fact that she's just trusted him with information she probably shouldn't have shared. "Now," he says, "you work under my direct supervision. No independent procedures. No decisions you make without running them past me first. And you tell me if anyone asks questions about your background." "And the decompression?" "Was textbook and necessary," Reeves says. "As far as the documentation goes, it was an emergency response to rapid decompensation. No one needs to know otherwise." Sarah feels the weight shift slightly. Not disappear. Shift. She's traded one kind of secrecy for another. Institutional protection in exchange for being known, at least partially, for what she is. Thank you, she says. Reeves nods once. The conversation is ending. The distance between them remains, but now it's understood. It's not ignorance anymore. It's the negotiated boundary between two people who know something true about each other. He leaves her at the window. The patient arrives by ambulance at 3:38 p.m. A construction worker, approximately 45, brought in from a site collapse. Debris fall. That's what the paramedics say. Blunt force trauma to the abdomen and left flank. The wound pattern is consistent with that story. Sarah is setting up the bay when he arrives. Reeves is present. He's been present for every trauma since their conversation, even when he shouldn't be. Watching. She's aware of this. She doesn't acknowledge it. The patient is conscious and in significant pain. BP 92/58. Pulse 118. The attending, Dr. Paulson, begins the primary survey. Abdominal palpation reveals rigidity on the left side, possible organ damage. The trauma is significant, but not immediately catastrophic. There's time to assess before surgical intervention. Sarah is documenting when she sees it. Not sees it with her eyes. Sees it with the part of her mind that learned to read injury patterns in contexts where debris meant something different, where collapse meant something different. The wound configuration is wrong for a simple debris fall. The abdominal trauma is correct for that mechanism, but the flank wound, the depth, the pattern of tissue damage, the way the shrapnel, there are pieces of metal embedded in the muscle tissue. Small pieces. The kind that come from fragmentation. The kind that come from explosives. She goes very still. Reeves sees her stillness. He's watching for exactly this kind of moment. Sarah moves to the bedside and examines the flank wound more closely. She doesn't ask permission. She's operating under his supervision now, but this is past that. This is recognition crossing into territory that has no civilian equivalent. Dr. Paulson, she says quietly, I need to examine the wound tract more carefully. There are foreign bodies here that need to be assessed for fragmentation patterns. Paulson looks at her. It's debris. We'll address it in surgery. But Sarah is already gently probing the wound, understanding the depth, the trajectory, the angle of entry. Her hands move through the assessment with absolute certainty. She's done this before. Not in a hospital, in a field environment. With limited equipment and the understanding that infection from embedded fragmentation could become sepsis in hours. The debris is metallic, Sarah says. She's speaking clinically, but her voice has shifted. It's become the voice of someone giving information based on experience, not hypothesis. And the fragmentation pattern suggests high-velocity impact, not gravitational collapse. The wound tract is too deep and too narrow for blunt force debris. The room has shifted. Paulson hears it. Reeves hears it. It's consistent with blast fragmentation. Sarah continues. The patient needs imaging to identify all foreign bodies before surgery. And if this site was an actual industrial collapse, you should call OSHA because this isn't consistent with that mechanism. There's a pause. A long one. Paulson is an experienced trauma surgeon, but she's never heard a nurse deliver a forensic wound assessment before. She's never heard anyone speak about blast fragmentation with that kind of automatic knowledge. How do you know that? Paulson asks. Sarah meets her eyes. She can feel Reeves watching from the corner of the bay. She can feel the moment crystallizing, the moment where her attempt at ordinariness becomes impossible. I've seen blast injuries before, Sarah says. It's the truth. It's also the beginning of her becoming something other than a rookie in this space. Paulson orders the imaging. The patient is moved to CT, Sarah follows, and Reeves follows her. In the corridor, he's close enough that his voice is only for her. That wasn't training, he says quietly. That was experience. Sarah doesn't answer. She's watching the patient being transported, already moving through the logistics of what comes next. Combat, Reeves says. It's not a question. Yes. Recent. She doesn't respond. Recent is relative. Recent enough that her hands remember. Recent enough that fragmentation patterns are still legible to her nervous system. Recent enough that recognizing a blast wound in a construction accident site makes perfect, terrible sense. The patient needs surgical intervention, Sarah says, changing the subject in the way of someone who has learned that some conversations don't have endings. The imaging will show what we're dealing with. After that, It's standard protocol. But they both know that nothing is standard now. The wall between her two lives has fractured completely. She's not hidden anymore. She's visible. And that visibility is changing everything about how she exists in this space. The federal agent arrives during morning rounds. She doesn't announce herself as federal at first. She walks into the trauma bay with a hospital credentials ID, introduces herself as Dr. Rebecca Chun, and asks to speak with the trauma chief about a patient. Her name is Rebecca Chun. Sarah's last name is Sarah Chun. The coincidence is either deliberate or meaningless, and Sarah can't determine which, so she assumes the worst. The patient in question is the construction worker from 2 days ago, the one with the blast fragmentation, the one whose wound pattern didn't match his story. Reeves is reviewing charts at the nursing station when the agent approaches. Sarah watches from the supply room, making herself invisible while watching everything. Dr. Reeves, the agent says, I need to ask some questions about a patient admitted 48 hours ago. James Morrison, admitted with injuries from what was reported as a construction site collapse. Reeves looks up. His expression doesn't change, but Sarah sees it, the recognition that this isn't institutional. This is outside. I can't discuss patient information without, Reeves begins. I'm aware of HIPAA, the agent says. She pulls out a federal credential. I'm Special Agent Rebecca Chun, Department of Defense. The incident that injured Mr. Morrison is under federal investigation. The injuries, as documented in your trauma notes, don't match the reported mechanism. Sarah's hands are very still in the supply cabinet. Reeves stands. He's tall, and the agent is shorter, but the physical difference doesn't matter. The power is already hers. Federal investigation. DoD credentials. Questions about wound patterns that Sarah specifically identified as consistent with blast fragmentation. Let's talk in my office, Reeves says. They move out of the bay. Sarah forces herself to continue the equipment count she was doing. 1 gauge needle. 2. 3. Her hands move automatically. Her mind is elsewhere, running through implications, scenarios, the reasons why a DoD agent would be investigating a patient's injury. Unless it wasn't an accident. Unless the construction worker was something other than a construction worker. Unless the collapse was something other than a collapse. Unless the blast fragmentation Sarah recognized came from something classified, something operational, something that brought federal attention. And unless whoever treated him before, whoever knew what his injuries actually meant, was also now under scrutiny. By 11:47 a.m., Reeves still hasn't emerged from his office. Sarah works through the morning shift with the sensation of waiting for collapse. Her competence doesn't falter. She assists with 2 routine admissions, manages equipment, coordinates with pharmacy. But underneath, she's calculating. If the DoD is investigating, they'll want to know who treated Morrison. They'll want to know who identified the blast fragmentation. They'll want to know who a former Special Operations Medical Officer is and why she's working in a civilian hospital. She's calculating whether she has time to disappear again, whether the job was always temporary, whether staying was a mistake. Reeves emerges at 12:34 p.m. He finds her restocking the crash cart for the 3rd time, not because it needs restocking, but because she needs to be doing something with her hands that requires concentration. My office, he says quietly. Sarah follows him. The hallway is empty. His office door closes behind them. She's investigating the patient's injury mechanism, Reeves says without preamble. The construction site story doesn't hold up. She thinks it was deliberate, a situation involving classified material or operations. Sarah says nothing. She's waiting for what comes next. She asked me about the trauma documentation. Specifically, she asked who identified the blast fragmentation pattern. Specifically, she wanted to know about your clinical assessment. Sarah's throat is tight. This is it. This is the moment where her presence in his hospital becomes a liability he has to manage. I told her, Reeves continues, that the assessment was mine, that I recognized the fragmentation pattern and documented it, that your role was standard nursing support. Sarah looks at him. She understands what he's just done. He's taken the identification, the expertise, the thing that connects her to her previous life, and he's claimed it as his own. He's placed himself between her and the federal investigation. Why? She asks. Reeves sits at his desk. He doesn't invite her to sit. Because, he says, you're a nurse in my trauma bay. That's the only thing that matters institutionally. If federal agents want to know about blast fragmentation patterns, they can ask me. I'm the trauma chief. That's my job. That's my responsibility. She could ask about my background. She could run a clearance check. She could, Reeves acknowledges. But right now, she has no reason to. As far as her investigation is concerned, you're incidental. A junior staff member who followed my directions. Nothing more. Sarah sits down without being invited. The weight of what he's done settles over her. The protection, the cost of it, the fact that he's now complicit in whatever she is. This won't hold, she says quietly. If she's thorough, then we'll address it when it happens, Reeves says. But right now, you need to assume you're being watched. The agent will be back. She'll talk to other staff. If anyone asks about your background, you refer them to me. You don't elaborate. You don't volunteer information. You become unremarkable. Sarah nods. She understands the protocol. Be useful. Be invisible. Don't draw attention. It's the same protocol that got her through the last decade. She also asked about your hands, Reeves says. Your precision with procedures. Your knowledge base. I told her you were well-trained and careful. That's all. Sarah feels something break inside her chest. Not suddenly. Like ice fracturing under weight. The ordinariness she was trying to build isn't available anymore. The federal agent has already registered that something is unusual about her. That registration will expand. That expansion could eventually reach her. Thank you, she says. Reeves nods once. Don't make me regret this. The patient arrives by private vehicle, carried by two men who claim they don't know how he was injured. He's approximately 30, conscious but deteriorating rapidly. Gunshot wound to the left thigh. Femoral artery involvement. Massive hemorrhage that's being barely controlled by a makeshift tourniquet. Sarah recognizes immediately that the tourniquet is incorrectly placed. Too low. Wrong pressure point. It's slowing the bleeding but not stopping it, and the damage timer is running. Reeves is in the bay. The federal agent, Special Agent Chun, is also in the bay, ostensibly observing for her investigation into the Morrison patient. She's watching everything, including Sarah. The attending physician on duty is Dr. Hayes, the pediatric resident who's been pulled into adult trauma coverage. He's competent, but not a trauma specialist. He assesses the wound and immediately calls for the OR. Standard protocol. Get the patient to surgery. Control the bleeding there. But Sarah can see what's going to happen. The patient is losing blood faster than the OR team can move. By the time he reaches the surgical suite, his pressure will be unrecoverable. By the time they get him on the table, the blood loss will have caused irreversible shock. She knows another way. It's not the standard civilian approach. It's what she learned in operational environments where you don't have 20 minutes to reach a surgical facility, where you have to control hemorrhage with what you have, now, in the field. The technique is called a pelvic binder application combined with aggressive wound packing, tourniquet repositioning, pressure dressing with hemostatic gauze, specific angles and pressures learned through hundreds of scenarios. It works. She's seen it work. She's done it before. But if she performs it, if she steps in and repositions that tourniquet with the kind of technical knowledge the procedure requires, she reveals exactly what kind of training she has. The federal agent is watching. Reeves is watching. Everyone is watching. Sarah stands at the supply station. She can see the patient. She can see his color shifting. She can see the moment where intervention matters. Hayes is focused on his own assessment, on moving the patient upstairs. He doesn't see what Sarah sees, that there's a window, a small one, where a different intervention could save this man's life. Reeves sees her. He sees her hands still at her sides. He sees her understanding. And he sees her decision. She doesn't move. She doesn't suggest the alternative approach. She doesn't offer the technique that would work because offering it would require an explanation she can't give. Not here. Not with the federal agent watching. Not with her clearance status unclear and her background under investigation. The patient is moved to the OR. Sarah finishes the equipment reset. Her hands move through the standard procedures with mechanical precision. She doesn't watch the monitor. She doesn't track his vital signs as they update. She doesn't allow herself to calculate whether he's still alive upstairs, whether he made it to the OR table, whether the surgical team had time to intervene. By 7:04 p.m., the update comes through the hospital system. Patient expired on the operating table. Massive hemorrhagic shock. Blood loss exceeded replacement capacity before surgical intervention could establish hemostasis. Sarah is restocking the crash card when she reads it. She doesn't stop moving. She doesn't pause. She just continues, one item after another, with the kind of discipline that keeps you functioning when you're breaking internally. Reeves finds her in the equipment room 30 minutes later. "You knew another way," he says. Not a question. "Yes. You could have saved him." "Maybe," Sarah says. She's focused on the crash cart. "Military medicine has different approaches. I could have suggested it. It might have worked. Or it might have delayed getting him to the OR, and he would have died anyway. It's a rationalization, and they both know it." "But you didn't try," Reeves says quietly. "Because the federal agent was watching." Sarah's hands still. She doesn't turn around. "I made a choice," she says. "To stay invisible. To protect what's left of my cover. That choice cost a man his life." Reeves steps closer. His voice is steady, but there's weight underneath it. "This is what you signed up for when you decided to hide," he says. "This is the cost. People die because you can't be who you are. People die because you have to follow protocols that aren't designed for what you know." Sarah finally turns. Her eyes are still that gray-blue, but they're different now. The distance in them is no longer composure. It's dissociation. It's the look of someone who's made the calculation and accepted the result. "I know," she says quietly. And then she returns to the crash cart, continuing to stock it with the kind of methodical precision that allows you to function while something essential dies inside you. The ordinariness she was trying to build has become a weight instead of a shelter. The cost of invisibility is now visible to everyone. The agent arrives with a folder and a patient record. She doesn't announce what's in the folder. She simply walks into Reeves' office where Sarah is present, ostensibly reviewing shift notes, and places it on his desk. Reeves opens it. Inside is military documentation, a discharge record, heavily redacted but bearing enough unredacted language to be unmistakable. Special Operations Command, medical officer, classification level that has been declassified for personnel review only. The name at the top is Sarah Elizabeth Chun. "I appreciate the effort," Special Agent Chun says, not unkindly, "but your background check had inconsistencies. Your nursing school timeline didn't match your employment history. Your references from County General were vague. So I ran a deeper query through DoD records." Sarah feels the moment arrive like physical impact. Not surprise. She's been waiting for this. Acceptance. The threshold has been crossed. "This is classified information," Reeves says, looking at the agent. "It was classified," the agent corrects. "Personnel records for medical officers aren't restricted from federal investigation when those officers are working in civilian facilities under assumed backgrounds. Ms. Chin's discharge was classified at the time. It's not anymore." She looks at Sarah directly. "Sarah Elizabeth Chun, former captain, Special Operations Medical Command, 10 years of active service, 3 operational theaters. Discharge listed as medical, reasons withheld. No subsequent employment history until 3 months ago when you applied for a nursing position under your civilian name, which happens to be your actual name, but presented as if you had never been anything else." Sarah doesn't speak. There's nothing to say that would change what's already been stated. "I need to know," the agent continues, "why a classified Special Operations medical officer is working in a civilian hospital under a false employment narrative. And I need to know if you're involved in any way with the patients who've come through this facility with injuries that don't match their reported mechanisms." Reeves looks at Sarah. His expression is carefully neutral, but she can see the question underneath. What has she brought into his hospital? Sarah takes a breath. She's calculated this moment 1,000 times over the past 8 days. The scenarios, the outcomes, the best way to make this simpler. "I needed to disappear," she says. Her voice is steady. "The work I was doing, the operational medicine, the combat environment, the decisions I had to make in fields without support, with resources that weren't adequate, with outcomes that were often fatal. It became something I couldn't separate from myself. I couldn't function in civilian life because I kept seeing everything through the lens of those years. Every interaction was a potential threat assessment. Every person was a clinical problem to be managed rather than a human to be present with." She pauses. Not for effect, just to organize the next part. "I took a classified discharge," she continues. "Medical discharge, though the medical issue wasn't physical. It was psychological. It was the recognition by my command that I was no longer effective as an officer because I was no longer functional as a person. So I left. I went to nursing school because I wanted to stay in medicine, but in a place where the work was different, where I could help people without the trauma, where I could be anonymous. And the patients with injuries that don't match their mechanisms? The agent asks. I've treated them, Sarah says. I've assessed them as medically as I could. I've followed protocol. I haven't identified their backgrounds. I haven't asked questions about how they were injured beyond what's necessary for clinical care. I've done my job. You've also done more than your job, the agent says. The Morrison patient, the decomposition assessment, the construction site incident. You recognized blast fragmentation. That's not nursing school knowledge. No, Sarah agrees. It's not. Are you in contact with anyone from your operational years? The agent asks. Anyone who might be using this hospital as a medical resource for operational activities? Sarah meets the agent's eyes. This is the real question. This is the thing that would make her a security liability. No, she says. And it's true. She's severed everything. She's been completely isolated. She's been nobody from nobody, working in a place where nothing connects to her previous life. The agent watches her. She's looking for tells, for hesitation, for the microfractures that indicate deception. She doesn't find them because Sarah isn't lying about this. She's been alone. That isolation has been the entire point. You're going to leave, the agent says finally. You're going to resign from this position. You're going to move to a location I provide, where you'll be monitored. And you're going to understand that if you have any contact with anyone from your previous service, that's considered a federal matter. Sarah nods. She expected this. She's prepared for this. She's been prepared for this since the moment she applied for the job, knowing it was temporary, knowing it would end. I'll submit my resignation today, she says. Reeves still hasn't spoken. Sarah looks at him. I'm sorry, she says quietly. I brought something into your hospital that wasn't what it appeared to be. You saved lives, Reeves says finally. His voice is carefully controlled. You also followed protocol when protocol mattered more than you. That makes you human, not a security threat. But the distance between them is now vast. She's no longer invisible. She's categorized. She's other. And that otherness is a weight that will follow her. Sarah has already printed her resignation letter when Reeves calls her back to his office. You're not leaving, he says. Not a request. The agent said, Sarah begins. The agent said you'd be monitored. She didn't say you'd be terminated. Federal oversight isn't the same as institutional termination. You were hired as a nurse. You've performed as a nurse. Your background doesn't change your job performance. Sarah doesn't understand. She's been preparing for departure since the moment she saw the file folder on his desk. She's already calculated where she'll go, how she'll disappear again, what shape ordinariness will have to take next time. The hospital's liability, she starts, is mine to manage, Reeves says. I'm the trauma chief. I made the decision to employ you. I made the decision to keep you after learning your background. That's institutional responsibility, not your burden. Agent Chin enters the office before Sarah can respond. She holds a document. Ms. Chin's employment status is a civilian matter, the agent says to Reeves. I have no authority to terminate her. I have authority to monitor her activities and to verify her compliance with federal restrictions. The restrictions are no contact with previous service members, no involvement in non-medical activities, and mandatory check-ins quarterly. Those restrictions don't prevent her from working as a nurse. She looks at Sarah. You stay, the agent says. You work. You live a civilian life. You understand that this is conditional on your compliance. Sarah nods slowly. She's not being exiled. She's being contained. It's a different kind of invisibility, not the absence of being seen, but the presence of being watched. 8:12 a.m. 2 weeks later. The trauma unit staff knows now. It happened gradually. Paulson mentioned something to another attending about Sarah's background. Hayes overheard a conversation between Reeves and the hospital administrator. By the end of the week, everyone in the Bay had a version of the story: classified discharge, special operations, federal monitoring. The versions weren't accurate. Some suggested she'd been fired and rehired as a condition of federal agreement. Some suggested she was undercover federal herself. Some suggested darker things, that she was dangerous, that she'd violated protocol, that she should have been terminated. What actually happened is simpler and heavier. She arrives for her shift, and the room changes. The other nurses still work with her, still coordinate, still communicate. But the texture is different. They treat her with a formality that didn't exist before. There's respect in it, genuine respect for competence that's now understood to be earned through real experience. But there's also distance. She's unpredictable to them now. not dangerous, but other. A resident named Dr. Patel arrives for his rotation, and someone explains the situation to him. He treats her differently from day one, deferential in a way that feels almost military, like he's interacting with a senior officer wearing a junior rank. Sarah hates it. She hates the visibility, hates being approached with assumptions, hates having to exist as the thing she was instead of the thing she was trying to become. By midday, she's documented 4 patient cases, assisted with 2 procedures, and managed the supply inventory. Everything is competent. Everything is correct. Everything is observed and slightly deferred to, as if the other staff members are waiting for her to make the real decisions. Reeves watches her during a routine wound assessment. The patient is a woman with a laceration requiring stitches. Nothing complex, nothing that requires her special knowledge. Sarah walks through the procedure with her usual precision, but her hands are tense. The ordinariness she's performing is performative now. Everyone knows what's underneath. After the shift, Reeves finds her in the staff locker room. "You're grieving," he says. Not a question. Sarah doesn't respond. She's changing out of her scrubs with careful, methodical movements. "You came here to be ordinary," Reeves continues. "And that's gone now. That loss is real. But what's replaced it is also real. What's replaced it," Sarah says quietly, "is being categorized. I'm no longer a rookie learning the job. I'm a former operator doing civilian work. Everything I do is interpreted through that lens now." Reeves nods. He understands the distinction. "You can leave," he says. "The agent's restrictions apply wherever you are. You're not trapped here." "I know," Sarah says. She's still not looking at him. "But leaving doesn't change what's happened. It just changes the location where I grieve it." She sits on the bench. Her voice is very quiet. "I had 3 months," she says. 3 months where I was just a person trying to learn a job, where my hands didn't mean anything except what they did in that moment, where I could exist without the weight of what I'd done before. That's gone now, and it's not coming back." Reeves sits beside her. Not close, just present. "What comes next," he says, "is integration, not disappearance, not hiding. You exist as both things, the person who trained in special operations and the nurse who works in a trauma bay. They're not separate anymore. They're just who you are." Sarah finally looks at him. Her eyes are the same gray-blue, but something has shifted in them. The distance has become acceptance. Not peace, just acceptance. "Okay," she says quietly. The patient arrives by ambulance. A man, approximately 55, cardiac event in progress. Acute myocardial infarction. The paramedics have already initiated emergency protocols. Oxygen, for access, continuous cardiac monitoring. The situation is straightforward by trauma bay standards. Not the most critical, not the least. A patient who needs immediate intervention but has a reasonable chance of survival if the intervention is correct. Sarah is at the supply station when he arrives. She doesn't move immediately. She watches. The attending physician is Dr. Morrison, competent but methodical. He's already making the call. Cardiology consult, preparation for emergency catheterization, standard protocol. It's the right call. It's not the fastest call. The patient's rhythm is deteriorating. Not catastrophically, but moving toward it. Sarah recognizes the pattern. She's seen it before. Many times. In places where waiting for cardiology wasn't an option. She moves to the bedside. "The anterior wall is showing ischemia," she says to Morrison. Not a question. An observation delivered with the absolute certainty of someone who's read this pattern in real time, in field conditions, with lives depending on speed of recognition. "We have maybe 4 minutes before this becomes cardiogenic shock." Morrison looks at her. He's aware of her background now. Everyone is. But the awareness exists differently in moments of crisis. In moments of crisis, competence is the only thing that matters. "I'm calling cardiology," he says. It's not defensiveness. It's protocol. "For minutes," Sarah repeats quietly, and then she steps back. She doesn't push. She doesn't override. She just states the fact and allows Morrison to make his decision. This is the boundary she's learned to maintain since her exposure. Offer information when it matters, but respect the authority structure that governs civilian medicine. Morrison pages cardiology with urgency. The patient is moved to the ICU waiting room to be closer to the catheterization lab. Reeves is in the OR, but the message reaches him. He emerges 12 minutes later, still in surgical clothes, to review the case. The patient is stabilized. The intervention happens. The outcome is positive. By evening, the cardiology team has restored blood flow, and the man's prognosis has shifted from critical to guarded but survivable. Sarah is restocking supplies when Reeves finds her. He doesn't speak. He just watches her work. Her hands move through the inventory with the same precision they always have, before her exposure, after her exposure. Nothing has changed in her competence. Everything has changed in how that competence is perceived. You knew, Reeves says finally. You knew what was going to happen before Morrison understood it. Yes, Sarah says. And you didn't override him. No. Reeves nods slowly. He's understanding something that has taken 6 weeks to crystallize. Sarah hasn't just been exposed. She's learned to exist with exposure. She's learned to offer her knowledge without demanding authority. She's learned to be a person carrying weight instead of a person trying to disappear. That's harder, Reeves says, than what you did before. Sarah looks at him. It's the first direct acknowledgement of what the cost has been. Not just the loss of ordinariness, but the discipline required to exist with visibility while respecting boundaries that she could easily override. Yes, she says. 11:47 p.m. Same shift. The bay empties as evening moves toward night. The staff begins their departure routine. Sarah finishes her end-of-shift documentation. She's meticulous about it. Every detail recorded, every decision justified, everything traceable to protocol. The other nurses pass her on their way out. They nod. They're cordial. They're also relieved to be leaving a space where she exists. She represents something that reminds them of the fragility of civilian safety, the knowledge that the people treating their injuries might have learned medicine in contexts where the rules are different. Reeves doesn't leave immediately. He reviews the final case with her, the cardiac patient, the decision to move him quickly, the outcome. It's a debrief. It's also something else. It's the only person in the hospital who fully understands what she carries. You did good work today, he says. I followed protocol, Sarah says. You did more than that, Reeves says. You recognized a critical pattern, communicated it clearly, and respected the physician's authority to make the final decision. That's not just good work. That's integration. Sarah closes her shift notebook. She's very still. I don't know what integration looks like, she says quietly. Before, I was one thing entirely. Then I tried to be something else entirely. Now I'm both things at the same time, and I don't know how to exist as both. Reeves doesn't have an answer for this. There isn't an answer. There's only continuation. Only the daily practice of showing up and being both the person she was and the person she tried to become, without resolution between them. You learn, he says finally. You show up. You do the work. And eventually, the two versions of you stop feeling like a contradiction. They just feel like who you are. Sarah nods. She doesn't believe this exactly, but she understands it. She understands that belief will come later, if it comes at all. She gathers her belongings. She walks through the trauma bay one more time before leaving, checking monitors that don't need checking, adjusting equipment that's already adjusted, performing the rituals of departure that allow closure. The fluorescent lights are harsh in the empty bay. She's alone in this space where she's been simultaneously unseen and intensely visible, where she's saved lives while following protocol and watched people die while maintaining invisibility, where she's been exposed and has chosen to remain. She turns off the lights. Outside, the parking lot is dark. The city moves around her, people going home, people arriving for night shift, the ordinary flux of a hospital that never truly closes. She's part of this now, visible, monitored, integrated into a system that knows what she is and has chosen to keep her anyway. It's not the ordinariness she wanted, but it's the ordinariness she has. She drives home through empty streets, her hands steady on the wheel, her mind already preparing for the next shift. The weight is still there, the memory of what she did before, the knowledge of what she chose not to do in the moment that mattered most, the isolation that comes from being seen. And